Today, we are very, very pleased to bring two experts in early mobility, Dr. Sue Siriani and Dr. Maria Palesci. Dr. Siriani celebrates her 30th year in nursing. She still feels that same sense of excitement and commitment with every patient and family encounter. Sue earned her Bachelor of Science in Nursing from the University of Windsor, a Master of Science in Nursing from the University of Phoenix, and holds certificates as Adult Nurse Practitioner and Acute Care Nurse Practitioner, as well as her Doctorate in Nursing Practice from Madonna University. Her doctoral research focused on improving sepsis care throughout 4 adult hospitals within the Detroit Medical Center. Dr. Siriani has presented extensively on sepsis, early mobility, delirium, reducing costs in healthcare, the ABCDEF bundle, and the role of the DNP, to name a few, both locally and nationally. Throughout her career, Dr. Siriani has been a staff nurse, preceptor, educator, clinical nurse specialist, and most recently, she is a nurse practitioner within the Surgical Intensive Care Unit at Sinai Grace Hospital in Detroit, and adjunct associate professor at Madonna University in the Acute Care Nurse Practitioner program. She's an active member and immediate past president of the Michigan Council of Nurse Practitioners, Metro Chapter, currently serving as the Region 5 representative over the 2 largest chapters in Michigan, along with 5 student chapters. Dr. Siriani's awards include Daisy Award for Extraordinary Nursing, multiple nominations for the Florence Nightingale Award, which she was then runner-up for in 2014 and winner of the award in 2015 for Advanced Practice Nursing from Oakland University. She won the Kappa Iota Mentor of the Year Award, American Association of Critical Care Nurses Circle of Excellence, the MICNP Metro Chapter Outstanding Nurse Practitioner, and Sepsis Alliance Nurses Know Sepsis Award in 2016. As a nurse practitioner in the SICU, Sue cares for critically ill and injured patients on a daily basis. She precepts nurse practitioner students and educates residents that rotate on her SICU service every month. In addition to her clinical work, she is actively involved in many hospital and system-wide committees, where she has developed and facilitated numerous evidence-based practice changes within the ICU, both at Sinai Grace and Detroit Medical Center. The work that she is most proud of are her efforts to raise public awareness regarding sepsis. After losing her brother to a 36-hour battle of sepsis, Dr. Siriani co-founded the first annual Stomp Out Sepsis with her research partner, Dr. Maria Palesci, who we'll learn more about in a moment. This year marks the 3rd Stomp Out Sepsis event, and both Dr. Siriani and Dr. Palesci have worked extensively with the Michigan Hospital Association, and they have now engaged others in Michigan to be active in raising public awareness. Their efforts didn't stop there. This year marks their 2nd international event, Scare Away Sepsis, in Windsor, Ontario, Canada. Sue has been featured in the neighbourhood news, on YouTube, and on CKLW radio, discussing the need for early recognition and treatment of sepsis. She hopes that through increased awareness by both healthcare providers and the public that sepsis will be stomped out. To introduce Dr. Palesci. She is a nurse practitioner and director of patient care services at Harper Hutzel Hospital and Detroit Receiving Hospital, Detroit Medical Center in Detroit, Michigan. She received her Bachelor of Science and Master of Science in Nursing from Wayne State University and Doctor of Nursing Practice from Madonna. Dr. Palesci has 43 years of experience in critical care nursing, with 22 of those years as an advanced practice nurse. Currently, she is the Director of Patient Care Services, including sepsis, stroke, and magnet programs. In addition to covering 3 critical care units, she has facilitated the development and implementation of many programs and protocols in the Detroit Medical Center, including sepsis care, the epidural pain service, early mobility, palliative care, prevention of hospital-acquired infections, ICU, pain, analgesia, and delirium protocol, as well as pressure injury prevention and management strategies. Throughout her career, she has facilitated staff involvement in the exploration and implementation of evidence-based practice at the bedside. Dr. Palesci is the co-chair of Detroit Medical Center Critical Care Committee and serves as an advisor for multiple shared decision-making councils in acute and critical care. She has presented her work at many conferences across the nation and in Canada. Her doctoral research project entailed improving bundle compliance for sepsis care at 4 adult hospitals, and along with her research partner, Dr. Sue Siriani, she advocates for increased public awareness in the Stomp Out Sepsis campaign. Through their efforts and in collaboration with the Michigan Hospital Association, they have raised funds and participate in several events across Michigan and in Canada. Dr. Palesci is currently a member of the American Association of Critical Care Nurses, Sigma Theta Tau, and Society of Critical Care Medicine. She also serves as adjunct professor and clinical preceptor at Michigan State University and the University of Detroit Mercy. She also precepts DMP students from multiple local and national universities. And she has also received many awards, including the 1996 recipient of Irene Beeland Award for Excellence in Medical Surgical Nursing and Commitment to the Improvement of Patient Care from Wayne State University. She was also a recipient of Florence Nightingale Award nomination in 2002, 2004, 2011, and 2012, and she went on to win this award in 2013 for her excellence in research and education. She was a finalist for the Sepsis Alliance Sepsis Heroes Award in 2016 and winner in 2017. She has also been active in facilitating facility awards, including national awards to recognize achievements in eliminating healthcare-associated infections, sponsored by the U.S. Department of Health and Human Services, Office of the Assistant Secretary of Health, and Office of Healthcare Quality, and the Critical Care Society's Collaborative Sustained Improvement Award for eliminating ventilator-associated pneumonia and central line-associated bloodstream infections. So with that, I am very pleased to bring you these two experts, and Dr. Palesci and Dr. Siriani, I am going to hand it over to you.
Thank you, Margaret, and thank you for inviting Dr. Siriani and I to speak on this important topic that is so near and dear to our hearts. So for our disclosures, we have no financial disclosures, but we do need to disclose that we are passionate about sepsis. We are positive that the application of the evidence will improve outcomes, and we intend on persuading you to join us. Our objectives today are just to describe the relationship of baseline mobility on post-sepsis outcomes, to discuss the impact of comorbid conditions on recovery from sepsis, identify implications for post-sepsis care. So we know, just like stroke and MI, we need to elevate sepsis treatment as a medical emergency. Treatment is time sensitive and delays increase mortality and morbidity. Sepsis is defined as a life-threatening organ dysfunction caused by deregulated host response to infection. That's the definition from SEP3. And it's the body's response to infection causing injury to its own tissues and organs. And sepsis really can be very vague. It's easily mimicked by other disease processes and is so often ignored or overlooked. So in the SEP3 definition from 2018, sepsis is a clinical state that's considered excessive, maladaptive, and abnormal. Sources include pulmonary, urine, intra-abdominal, blood, skin, invasive lines, and tubes. There are two possible theories that have emerged that help explain the nature of this type of deregulation. There's a platelet pathogen theory that suggests pathogens bind to the platelets and activates them, and these platelets then bind to the endothelial cells and immune cells and then cause damage and disruption, leading to a loss of the integrity and fluid leakage, resulting in shock. And then there's another theory that talks about endothelial pathogen, where the pathogens bind to the endothelial cells and activate them, and then they release those pro-inflammatory cytokines and chemokines, and that activates the platelets to form a thrombus and causes a whole excessive cascade of thrombocytopenia and hyperinflammatory responses, and increasing vascular permeability and that fluid and leakage and then shock. So it's your body's way of reacting to that dysregulated process. The infection plus the sequential organ failure assessment, when you have more than or equal to 2 of the assessment points, whether it's oxygenation, mental status, hypotension, liver dysfunction, or kidney dysfunction, or even hematologic dysfunction. That lends itself really to the sepsis diagnosis. So for us, it's very personal, as you heard from our bios. Dr. Sirianni's family, her brother died of septic shock from necrotizing fasciitis. Her aunt also passed away from a central line infection with permacath. For me, my mom presented in septic shock from C. diff and aspergillus when she was diagnosed with leukemia. My father just last month had a UTI and was in septic shock when he presented to the emergency room. And then my daughter-in-law. So my daughter-in-law was rushed to the hospital, but my son, he suspected she was septic from mastitis. And she went to the ED in septic shock, and this happened overnight. So it can happen to anyone. So how can we improve sepsis recovery? Well, all we have to do is use the evidence. Use the evidence-based interventions such as the 3-hour bundle, blood culture ×2 with a lactate, broad spectrum antibiotics, timely administration of those antibiotics, fluid resuscitation if the MAP is less than 65 or the blood pressure, systolic blood pressure less than 90, and or a lactate of greater than 4. And of course, source control, finding out where that infection is and getting rid of it and treating it. The other evidence-based intervention is 6-hour bundle. They must, of course, be completed within that 6 hour of time 0. The patient remains hypotensive or has a lactate of greater than 4. They require minimally 30 mils per kilo of fluid resuscitation. Vasopressors to keep that mean arterial pressure or MAP greater than 65. Looking at patients if they're lactate and trending their lactates to see if it remains greater than 4. And then remeasuring that lactate to ensure that we're fluid resuscitating the patients enough to reduce the hypoperfuse state. So the global burden of sepsis, we have over 48.9 million cases of sepsis annually worldwide. And of course, this is pre-COVID. So 37.9 million patients will develop severe sepsis annually, and more than 11 million people will die. It affects, in the United States, 1.7 million. That means around 1 every 20 seconds, and that is increasing by approximately 8% every year. Sepsis is the leading cause of death in the non-coronary ICU. The cost of hospitalization in the United States is greater than $24 billion per year. It's the #1 cause of readmission to hospitals, costing more than $2 billion a year. It accounts for more than 12% of all hospital readmissions. Here's Rory Staunton. He is a 12-year-old that died from a sepsis-related injury, a scrape from a playground. His family started this foundation in his honor to advocate for sepsis prevention. And you can see from this graph that sepsis kills more people than deaths from AIDS, opioid, and breast cancer combined. Our Medicare beneficiaries, if you look at the data from 2012 to 2018, You can see a steady rise in the sepsis inpatient admissions, the length of stay. You can see even just for 7 days, those patients who are admitted for more than 7 days, it went from 12% to 22% in that time frame. So the morbidity associated with sepsis survivals, we know that improvements in care have occurred. As you can see, the data between the 90s and 2015 went from 60% to 74%. But these patients have a 3 times higher cognitive impairment. They have more functional limitations. They're at higher risk of rehospitalization and a higher risk of death. 1/5 have deaths later on in their course that are not even associated to any type of pre-sepsis health state. 1/3 of patients do not even return to independent living after 6 months. Long-term health-related quality of life outcomes are worse in the sepsis survivors than as compared to any other patient. Some of the other common lasting effects: muscle weakness, patients are fatigued, they have cloudy thinking, they can't sleep, they're sad, they have poor memory, they're anxious. And the cognitive impairment in these sepsis survivors, memory, learning, concentration, making, really it affects the patient's daily lives, their lives and the lives of their caregivers and families. And the mechanisms are truly not fully understood, but probably likely due to the many immune alterations and the cytokine releases that I talked about a little bit earlier. Some other risk factors associated with poor long-term functional outcomes: the duration of delirium while they were hospitalized, if the patient is hearing impaired, if they were immobile, frail, patients that are older, have premorbid disability, lived in a nursing home, the severity of their acute illness, if they have vision impairment, and no spouse. So here's the first polling question slide. What are the lasting effects of sepsis? Choose all that apply.
Maria and Sue, the poll results said that moderate to severe cognitive impairment, higher risk of readmission and death, and new functional deficit, unable to live independently at 6 months. Nobody chose better socialization and memory or the improved sleep and life quality.
Okay, good job with the poll. So survival after sepsis, the moderate to severe cognitive impairment, as you can see from this information from posted, that there was an increase in this study from 6.1 to 16.7% in participants in the U.S. Health and Retirement. The moderate to severe cognitive impairment in this research study increased from 6.1 to 16.7 in participants. They said that there were some alterations seen not only in memory, but attention, verbal fluency, and executive functioning. Patient outcomes. In the study by Mostel in 2020, approximately half of the patients who survived a hospitalization for sepsis achieved a complete or near complete recovery at 2 years, but 1/3 of the total patients died during that 2-year period, and 1/6 of these patients remained with one or more serious lasting complications post-sepsis syndrome. So negative outcomes associated with sepsis: decreased 6-month survival, increased hospital mortality, increased duration of mechanical ventilation, an increased ICU length of stay. The physiologic stress causes increased catecholamine release, increased oxygen consumption at lighter sedation levels, but they really saw no clear relationship between elevation and clinical outcomes. Post-sepsis syndrome is seen in many of these patients. They have neuromuscular weakness, disabling muscle and joint pain, chronic pain, PTSD, depression, insomnia, nightmares, hallucinations, loss of self-esteem. No long-term outcome guidelines or recommendations, though, have been developed, and many patients are truly not satisfied with the type of support services that they receive when they get home post-sepsis. Here's a schematic illustrating the reasons for functional decline. Patients with severe sepsis in the hospital are immobile, they have delirium, they end up with muscle remodeling because of decreased protein and increased fat deposition, muscle atrophy, fatigue, a decrease in their cardiac output, a decrease in their bone mineral density. And the systemic inflammation that occurs causes skeletal muscle breakdown, proteolysis, decreased protein synthesis, a dysregulated endocrinopathy with IGF and growth hormone, implicated cytokines and proteins that we talked about earlier, TNF, alpha, interleukin 1, interleukin 6, and an increased oxidant burden. So this all causes this functional decline and enduring morbidity for these patients. Here's another poll.
What are the factors that improve sepsis recovery? 3 and 6 hour sepsis bundle, managing pain, agitation, and delirium, the right medications, peer support, or resting for long periods of time. Everybody feels that the factors that improve sepsis recovery are 3 and 6 hour sepsis bundle, and 50% felt managing pain, agitation, and delirium, the right medications, peer support. Nobody chose resting for long periods of time. So back to you, Maria.
Okay, I think now, Sue?
Thank you very much. So we heard all the bad things that sepsis can do, but there are a lot of things that we as healthcare providers can do in order to help improve the recovery of sepsis in our patients that we care for. Dr. Pelesci talked about good sepsis care, which is the practicing of the 3 and the 6 hour bundle, implementing that evidence. And that has shown time and time again that that improves sepsis outcomes. I'm going to spend some time and I'm going to talk about prevention and management of pain, agitation, and delirium, de-escalation and de-resuscitation of care, medication, providing anticipatory guidance, exercise, anticipating and mitigating preventable rehospitalizations, the importance of peer support, and care alignment or goals of care. Next slide, please. In order to improve sepsis outcomes, I like to say it's as easy as A, B, C, D, E, F. A being assessing and treating pain. B is going to be our spontaneous awakening trial. C will be our choice of sedation. D will be the management and evaluation of delirium. E is early and progressive mobility. F is getting the family involved, getting our patients fed, and G is getting our lines and tubes out. And along with importance of awakening is also sleep. For the longest time, we've kind of not really considered sleep important in our critically ill patients because we have no problem continuing doing Q&R neural checks until the cows come home. But we know that that disrupts sleep, which makes our patients unable to participate in their weaning trials if they're too sleepy, unable to participate in exercise, and just creates a vicious cycle. So as part of improving sepsis recovery, we need to make sure we're following the PADIS guidelines. And probably the first thing and most important thing that we need to do is really to assess our patients and treat them for pain. And we need to recognize that even our patients who can't verbalize that they have pain. If any one of us was in an ICU bed or in a hospital bed with tubes coming out of every orifice, I'm sure we would be having pain. Or we've fallen, we've had a heart attack, we've had a stroke, we're going to have pain. So it's important that we use evidence-based pain management, and it's important that we use different types of pain management strategies. We like to incorporate multimodal pain management. You can use some acetaminophen or Tylenol around the clock. If you have patients that have brain injury, codeine tends to cross the blood-brain barrier better. That might be a choice. Certainly you can use narcotics, muscle relaxers, or GABA analogs if the patient has neuropathic pain, like using something like Neurontin. And using enough pain meds so that our patients are comfortable and able to participate in care. Opioids, you can use fentanyl. It's a great choice in your mechanically ventilated patient because it does not have the hemodynamic effects that some of our other narcotic analgesics will have. Alternatives for fentanyl, because it is very short lasting. You could use something like hydromorphone or Dilaudid, and then morphine if your patient is hemodynamically stable and has no renal failure. But it is really important that we treat pain in our patients. Otherwise, our patients will become agitated, they will become hypertensive, and they will not be able to participate in their mobility program. So in terms of management of our patients and our goals of sedation, we want patients to be calm and comfortable and cooperative. I always like to joke and say that it's not sedate to coma. You know, if you're going to have to use sedation, you want to make sure that the patient is still able to participate. It is important that we reduce their anxiety and agitation in order to help facilitate mechanical ventilation. I know it would not be comfortable to have a breathing tube in anybody's airway, so we want to keep them comfortable but not over sedated. And being in the ICU is definitely a traumatic experience for patients. We have all kinds of tubes in them. We have people coming in and out of the room at all hours of the day, and it can be a very traumatic experience. So we want to make sure that they don't have a lot of recall of what's happened in the past. Important information regarding sedatives. You should not put sedatives on until you have adequately managed your patient's pain. Always give your analgesics before you start with sedatives. And you want to start with push doses of sedatives as opposed to going right to a drip, unless you're going to be using something like dexmedetomidine or what we call Precedex. That's a great agent for patients that have ETOH withdrawal. However, one of the big side effects of that is that it can cause hypotension and bradycardia. So be judicious with the use. Make sure you are not going to put it on a patient that already is hypotensive or a patient that has a tendency to be bradycardic. Midazolam is another option we can use to sedate our patients, again, after we have provided pain management for them. Always start with IV push doses and don't proceed to a prolonged drip unless you're unable to sedate the patient. We know that using benzodiazepines precipitates delirium. It increases how long patients are delirious, so we really want to avoid benzodiazepines if possible. Lorazepam, of course, is another benzodiazepine. And then propofol is another excellent agent that we can use to sedate patients. It's great for neurosurgical patients because it does allow you to wake them up quickly so you can do a neuro exam on the patients. However, please remember that propofol does not have any analgesic properties. So if you just put propofol on the patient without any analgesics, that patient will require a lot of propofol to be comfortable, and that will then lead to hypotension and worse outcomes in your patient population.
Which sedation practices improve delirium? Check all that apply. So the first one, use of benzodiazepines for sleep. Treat pain before agitation. Fentanyl preferable to morphine and Dilaudid. Early and progressive mobility. Multimodal medications, ATC. Check all that apply. Poll, and the results of the poll are 100% of you felt that use of benzodiazepines for sleep was not the right answer. Treat pain before agitation. Fentanyl preferable to morphine and Dilaudid. And 50% of you thought early and progressive mobility, and 50% thought multimodal medications, ATC. So Dr. Suryani, you want to address that?
Great that everybody knows that you should treat pain before agitation, because remember, pain is often a cause of agitation in our patients. So often if you treat the pain, you don't need to do anything in order to treat their agitation. Fentanyl is preferable if you have a patient that's hemodynamically unstable. But again, fentanyl has a very short half-life, so that's kind of a 50-50 question. And then early and progressive mobility definitely helps decrease delirium, helps to decrease how long patients are delirious, helps them feel like they're making progress. So it's a great thing. And multimodal medication, you want to make sure that you're providing your patients with good pain control in order for them to participate in their activities, especially when you're starting to get patients up that have tubes in lots of different orifices. It's good to use multimodal pain medication. We know that immobility leads to functional decline. So using your physical therapist and employing early mobilization helps to mitigate some of the functional decline that occurs by preventing bed rest. I've been a nurse for a long time and worked in the ICU pretty much my whole career. And I can remember a time when the first thing you did when the patient got to the ICU is you hung your morphine and your Versed drip so that the patient had a nice, quiet stay in the ICU. Well, fast forward several years and we learned that that practice really created a lot of delirium in our patients. It created a lot of functional decline. We know that early mobility also helps prevent mechanisms that lead to sarcopenia. So if you don't use your muscles and you don't use your bones, they're going to just waste away. And if you have a patient in your hospital long enough, you will see how much muscle wastage they have. I can tell you my mom was in the hospital on and off since April, and she has lost probably 50% of her muscle mass because they did not do very much early mobility with her. And she is a perfect example of all the bad things that can happen when you don't get up out of bed. Early mobility also increases your pulmonary and tissue aerobic capacity, and it improves your sense of well-being. Patients who get up and walk have such a sense of accomplishment. Imagine if you've been laying in that bed for a week and all of a sudden you now are able to sit up at the side of the bed by yourself. It does wonders to help improve their motivation to continue to get better. Early PT and mobility in the ICU has been shown to decrease the number of ventilator days or increase the number of ventilator-free days. Patients who have early and progressive mobility have better functional status at discharge because you're preventing that muscle wasting, and they have a shorter duration of delirium. Next slide, please. So early mobility helps prevent or minimize muscle atrophy and shows promise for preventing some of the sepsis sequelae. So if you think about sepsis and mortality from sepsis, if we look at even 10 years ago, the mortality from sepsis, especially septic shock, was very, very high. And now, because we have better ways of treating sepsis, we've employed the 3 and the 6 hour bundle. We have improved our ICU care where we're not sedating patients and keeping them in bed for days or weeks at a time. We now are seeing all the effects that have happened to people who survive sepsis because more and more people are surviving sepsis. So it is really important that we try to do everything we can to help improve their recovery. There are some international guidelines that have been developed that recommend early mobility in the hospital. And what they did by employing these guidelines is they showed a shorter time to ambulation and a shorter duration of delirium during hospitalization. Patients also had improved physical function at hospital discharge. And especially in our elderly population, you really want them to be able to go home as opposed to going to a nursing home. If you're an elderly person and you go to a nursing home, that's the last place that you go. So if we can get people back to their home by keeping them as mobile as possible when they're in the hospital, they will have a better chance of going home. There still needs to be a lot of research done in terms of when should we start early mobility. Do we start it, as soon as the patient's hemodynamically stable? Do we start doing a little bit even when they're, hemodynamically unstable? Those questions are still unanswered. We know that we certainly need to do passive range of motion as soon as patients hit the door because we definitely don't want them to develop contractures. But how soon is soon enough? I say the sooner you can do it, the better. So the guidelines recommend that critically ill patients undergo rehabilitation in an ICU We know again that it decreases the incidence of delirium, it improves physical function and the activities of daily living in the ICU patient. Having patients help with their ADLs, having patients, brush their own teeth, wash their own face, that does a lot for their morale, and it also does a lot to help keep their muscles moving. It improves psychological and cognitive functions. It promotes social participation and increases the opportunity to return to work. Remember, our goal when we're taking care of these patients is to get them back to their families and get them back to their normal life, or as normal as life as possible. It's important that we have strategies in place to enhance recovery from critical illness and improve the symptoms of post-intensive care syndrome. PICS, or post-intensive care syndrome, has so many ill-lasting effects that anything we can do to help mitigate those is really going to help your patients in the long run. So goals of early mobility are to decrease the amount of physical disability. They're to prevent additional neuromuscular complications such as contractures, muscle wasting. They're also to help prevent pressure ulcers. Again, as I said earlier, it helps promote a positive psychological output for our patients. It reduces ICU and hospital length of stay, and it reduces delirium. Patients who do not achieve early mobility show no improvement in their physical dependence up to 1 year after ICU discharge. So what we do in those couple of days or first weeks or two in the hospital or in the ICU really do impact the patient's life when they leave us. So going back to that slide that looked at 10 things that improve sepsis recovery, we talked about good sepsis care, prevention and management of pain, agitation, and delirium. And I want to spend a minute and talk a little bit about de-escalation and de-resuscitation of care. So when patients come into the hospital and they're critically ill, we throw lots of different medications on them. If they develop delirium, we'll often throw some antipsychotics on them. We'll have them on, multimodal pain medication, and then they leave the ICU, they go to the floor, they go to the nursing home, they go to the rehab, and often we don't ever take away those medications that were started acutely for their episode of sepsis or their episode of delirium. So it's important that every day you review what medications that patient is on and look at what can you start taking away. I can't tell you how many times we've had patients get discharged and then they get readmitted to the hospital, and we started them on things like Seroquel because they were delirious in the ICU. They didn't have a past history of psychosis, but yet they come back still on those medications. So as healthcare providers, we need to do a better job of de-escalating and de-resuscitating. So that goes along the lines of, if the person was getting 200 cc's of fluids, you got to remember at some point to back off those fluids and make sure that they're not volume overloaded. And medication reviews. Sometimes patients come in and they're too sick to get restarted on their regular home medication. So we don't treat their heart failure. We don't treat their gout. We don't treat some of their other medical conditions. And then all of a sudden they end up with complications as a result of not treating those other comorbid conditions that they have. And another important thing is to provide some anticipatory guidance for these patients. We need to tell them that life is going to be different after having had sepsis. We need to tell them that their exercise tolerance is not going to be the same. So many patients think, well, I'm tired, maybe I should just rest and not get up because I feel short of breath when I get up, or I feel really, really tired. So maybe if I just rest longer. And so they don't move around, and that just complicates their recovery even more. And so many of these patients develop some issues with aspiration and with being over volumized, as you want to say, or having too much volume on board. So we want to make sure that we are checking to make sure that they're not silently aspirating. We want to make sure that they don't develop acute kidney injury. If we need to adjust their medications while they're here, we need to do that. And give them an opportunity to have some peer support, because dealing with all of these post-sepsis complications are very, very difficult. I've spoken with a lot of patients that have gone to their doctors and the doctors really have told them, well, there's really nothing wrong with you, yet they have all these symptoms of post-sepsis syndrome. So putting them in contact with other people that have been through the same type of sepsis that they have or have the same complications as they have. There's a support group on Facebook for quadruple amputees after sepsis. They call themselves the Quad Squad. So there's a lot of different Facebook groups for sepsis support as well. So helping people to get in touch with other survivors of sepsis and having the discussion about goals of care. Our population is getting older and older. We're seeing multiple admissions in some of these older patients. So really having that discussion of goals of care, because once you've had sepsis, your chance of having sepsis again is very, very high. So do they want to come back in the hospital? Do they want to get reintubated if that becomes an issue? So a lot of things we can do for our patients to help improve care. This is something that's going to take lots of different disciplines in order to help our patients have the best sepsis outcomes. One of the things that has recently been identified is that sepsis is not a single syndrome. Very similar to cancer, we're finding that there's not simply one type of condition, but many conditions that may require different treatments. So there is a large study that was published in Emergency Care, and it looked at 29 EMR clinical records of 60,000 septic patients within 6 hours of coming to the emergency room. And they really did find that there's a lot of differences in how patients present and how they react to their sepsis. And if you look at patients, you might have two patients that have the same bug, but they have very different outcomes. Even looking at clinical trials, we know that there's a wide variation in results in a lot of the clinical trials. So why is that? If people are getting the same treatment, you would expect them to have the same results, and we know that that's not the case. So what they've identified is that there are 4 subgroups or subtypes of sepsis. The alpha, which is the most common type in about 33% of patients, are the patients that come in. They're the least sickest patients. They have the fewest abnormal labs, they have less organ dysfunction, and they have the lowest in-hospital death rate. Whereas if you look at the beta group, there tend to be older patients. It accounts for about 27% of patients. And these are the patients that have chronic illnesses and kidney dysfunction. The gamma group accounts for about 27%. And this is the group that has increase in inflammation and primarily pulmonary dysfunction. And then the delta group, which I'm going to hazard to guess that my brother probably fell into this group, is the least common, about 13% of the patients, and it's the most deadliest type with liver dysfunction and shock, and that accounts for about 32%. And these are the patients that come in, and it seems like even though you do your good sepsis care, they end up dying. So there's a lot more research that needs to be done in terms of determining what treatment works best depending on the subcategory of sepsis that you have, or the group that you're in. Are you an alpha, are you a beta, are you a gamma, or a delta? Perhaps all of the studies that have been done, you have a combination of alpha, beta, gamma, and delta patients in that group, and that's why we're getting results that vary so much. So the researchers have reviewed data from trials that have not been successful. So the early goal-directed study in 2014 that was done looked at a 5-year study and showed no benefit. But when the team re-examined the results of early goal-directed therapy plus the alpha type, they had a worse outcome for that delta subtype. So there is a lot more work that needs to be done. We need to replicate a lot of these studies similar to how we treat patients with different types of cancers in order to find the therapy that best targets the specific type of sepsis syndrome that they have. So to conclude, the natural history of recovery after sepsis is not well understood. Multiple recovery phenotypes are likely due to a complex and variable pathological response to sepsis. So we know that people respond very, very differently. As I said, you can have two people with the exact same bug, pretty much the same comorbid conditions, kind of same health status, and they have very, very different outcomes. So several prognostic factors for more complete recovery have been identified, including pre-existing disability and frailty as predictors of reduced likelihood to regain functional independence. So again, if you have somebody who comes into your hospital and they are elderly, they are frail, they are have a significant amount of pre-existing disability. That's the group that we really need to target and start working with very, very early, because we know that they're only going to get more and more debilitated and more frail and deconditioned as they stay in our hospitals. So improved outcomes for patients with sepsis combined with a rise in survivorship have warranted considerable research and clinical efforts focusing on life during and after sepsis. So we really need to get involved and start doing our own studies to see what is it that really improves survival in our patients, and not just survival so that we can get them home or get them to a nursing home, but get them so that they have a good quality of life. Recent studies have found that survivors of sepsis are subject to several categories of complications, as we discussed earlier. They really become immunocompromised, they have neurocognitive effects, psychiatric effects, and a lot of physical derangements that lead to an increased mortality and severity, worsening their quality of life. So healthcare professionals and family members as well pay a heavy cost in both money and energy. Taking care of these patients with post-sepsis syndromes can be very, very challenging. They have a lot of physical needs and they have a lot of emotional needs that need to be met by both the healthcare professionals and family members. So physicians or nurse practitioners or PAs who are seeing patients in the office who are coming to you after they've had sepsis that tell you, you know, I'm having all these terrible dreams, I'm feeling really, really weak. We need to acknowledge that what they have is in fact post-sepsis syndrome and help them with some of the strategies, you know, get them into peer support, counsel them on, you know, what they can do to help mitigate some of these symptoms. So goals of care for patients who survive sepsis include using approaches that are effective, including our early sepsis care while they're in the hospital, controlling their pain, agitation, delirium, and improving sleep, and of course, early mobilization. So it's important that we implement an interprofessional approach to early, progressive, and aggressive mobility in order to combat the effect of bed rest and delirium. So the sooner you can start your mobility, the better. Whatever that patient can do, if they can do only 1 minute that first time sitting up at the side of bed, that's great. The next time, tell them we want them to try 2 minutes. If they can walk 5 feet, tell them the next time we want them to try 10 feet, and just keep challenging that patient so that they can have a better outcome when they leave your hospital. So early mobility improves functional independence, it improves sleep quality. I always like to tell our nursing staff that if they get the patients up, you know, between 7 and 10, they'll have a better night because the patient will sleep a little better. It improves muscle strength, the likelihood of discharge to home or rehab versus going to an extended care or a SNF, and it really improves their quality of life. It also helps to reduce ICU and hospital length of stay, time on the ventilator, pressure ulcers, ventilator-associated events like pneumonias, readmission and death, cost of care, hyperglycemia, inflammation, and delirium. So when you are mobilizing your patient, you help to mitigate all the bad things that happen from laying in bed. So get your patients out of bed, the sooner the better. Challenge them, push them a little bit, because sometimes it hurts, they don't want to do it. But we know in the long run, we're only helping our patients to have a better outcome when they leave us. Thank you.
We do have a couple of questions. Can you share if there are any specific precautions or parameters for mobilizing patients with sepsis?
The parameters would be related to their hemodynamic status. So if you sat them up and they got hypotensive, then that would kind of be your telltale sign that not to get them up. If they had any contraindications to mobility because they had some sort of fracture that you know they could not bear weight on, or if they had an unstable fracture.
Okay, and another question, thank you. Are there any specialty programs you're aware of for post-sepsis rehab, similar to cardiac or pulmonary rehab?
I am not aware of one. I think they are working on something at U of M in Michigan, but I'm not positive. Maria, do you know?
I think they were talking about starting, if they haven't started, a PICS clinic, so post ICU clinic. that might would see that type of patient, a septic patient. But program-wise, I am definitely not sure. I said it's a great idea.
Okay, yeah. And then the third question that I have here, do you see post-sepsis symptoms even without ARDS or multi-organ failure or dysfunction? Or is the symptoms a combination of all the things and not just sepsis on its own?
Well, from a personal perspective, I can say that I've seen patients that have had those types of concerns after being septic, and they didn't have the severe or septic shock. Even in my family, you know, they had nightmares, the lethargy, a lot of the memory things that were associated with the sepsis followed them for quite a while. They just weren't right afterwards, but I think that's pretty common with most patients that have sepsis. Sue?
I agree with Maria. I can say my mom has been septic a few times from UTIs, and same thing, like the muscle weakness and the debility really continues. And she didn't end up intubated or anything like that. She was hypotensive and had a UTI, so she had severe sepsis. But she still.
But the cognitive concerns happen afterwards too. Not so much with my daughter-in-law, but with both my parents. I think they both have suffered.
I think especially if you're elderly, the cognitive factors, it really plays into quite a bit.
Great. Well, thank you very much, Dr. Palesci, Dr. Siriani, for great information. And if there are any additional questions, please reach out to us at earlymobility.com and mark your calendars for our next webinar, which will be on December 4th and is going to cover tips and strategies to achieve success in implementing and sustaining your early mobility program. And please share with us on the evaluation any other topics that you would like to see as webinar content. This will conclude our webinar today. Thank you all for attending, and thank you again to Dr. Palesci and Dr. Siriani.